Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 16D, which is Hematology Disorders of WBC series. We are streaming live from PGI Chandigarh via Kolkata. We have a very interesting, intriguing topic, Inflammatory and Malignant Histiocytosis. To talk on that, we have Dr. Harpreet Virk. She's an MD Pathology from PGI Chandigarh. Currently, she's doing DM Hematology in Hematopathology as a fellow in PGI Chandigarh, with areas of interest in automation in hematology, Flowcytometry, and in benign hematology, with multiple publications in international and national journals. Before I ask Dr. Harpreet Virk to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Harpreet, ma'am, please start. Thank you, sir.
Okay, sir. Thank you. So good evening, everyone. At the outset, I would like to thank Nadeem, sir, and the team for giving me this opportunity to present this lecture in this series. So the topic is the inflammatory and malignant histiocytosis. So this tend to be a little theoretical topic, and because we don't see these conditions quite often in our routine practice. But I have tried to accumulate some of the cases that I came across during my residency and some of the important points that help in clinching the diagnosis in these conditions. So just a recapitulation of what is these histiocytes. So I would like to start my discussion with the mention of this pathologist. His name is Mechnikov, and he is the one who discovered the phagocytosis and macrophages, and he was awarded Nobel Prize in Physiology and Medicine for his work in immunity. So in mononuclear phagocytic system, we have two important components. One is your monocytes and macrophages, and one is your dendritic cells. So we have to first understand that these are two different components and there are two different lineages. So monocytes and macrophages are mainly involved in kind of phagocytosis, whereas the dendritic cells are mainly involved in the antigen presenting cells. So this slides, which I have taken from this reference written below, this shows the origin of these different components. So during the fetal life, the yolk sac and the liver produce the macrophage and the hematopoietic progenitors, and these are transferred to various tissues, interstitium of various tissues, and these includes the Langerhans cells, the microglial cells, and the histiocytes. But these basically are present at birth, and these are long-living and self-renewing cells. But upon inflammation, these are largely replaced by some cells which are derived from the bone marrow, and these are our area of interest. So the bone marrow has this hematopoietic stem cells which give rise to granulocytic monocyte progenitors and further monocyte dendritic cell precursors. So both the dendritic cells and monocytes have a common precursor, and then it differentiates into different lineages. So the common dendritic cell precursor give rise to further the plasmacytoid dendritic cells and the classical dendritic cell precursors. And the common monocyte precursor give rise to our monocytes, which further give rise to tissue macrophages and something called monocyte derived dendritic cells. And as I mentioned, they also replace the tissue resident macrophages. So coming to the monocytes and macrophages, so human monocytes mature in the bone marrow, and from there they are subsequently transferred into the blood as the classical monocytes. So the CM stands for classical monocytes, and these are CD14 positive and CD16 dim. So CD14 is highly expressed in these cells, and 16 is dim expressed. Another important markers which help to differentiate these classical monocytes from the other two important monocytes, which I'll talk later. These are called the intermediate monocytes and the non-classical monocytes, the NCM and the IM. So these classical monocytes, first of all, we have to remember that these are CD14 positive, and another important antigens which they highly express is this CD36, CD64, and this CCR2. So CCR2, we have to remember, they are expressed on these classical monocytes. These classical monocytes have their function in phagocytosis, in endothelial adhesion, migration, and in the general antimicrobial responses. These classical monocytes then give rise to something called intermediate monocytes, and these intermediate monocytes are show very high levels of CCR5. So these classical monocytes were high level of CCR2. These are high levels of CCR5, and they have the function in antigen presentation, regulation of apoptosis, and transendothelial migration. Finally, we have something called non-classical monocytes, and they are divided into some by this protein which is called SLAN. So SLAN is the protein in which non-classical monocytes are further classified into SLAN positive and SLAN negative. But what we have to remember here is that the non-classical monocytes have a 14 dimmer expression and 16 higher expression. And also one more antigen which is very highly expressed on these is this CX3CR1. So this is something very important molecule which is expressed on these non-classical monocytes. So these non-classical monocytes have a very distinct crawling pattern or very distinct moving pattern compared to classical monocytes, and these non-classical monocytes are sometimes also referred to as patrolling monocytes. And they basically have a function in protection of the vascular endothelium. So they are basically helpful in maintaining the vascular homeostasis. This slide shows the role of the monocytes and macrophages in various diseases which the scientists have studied over the past many years. But what is interesting here, which I also came across recently, is that the monocytes, this classical and non-classical monocytes differentiation is changed by our lifestyle. So the diet influences these expression of non-classical monocytes to a large extent. For example, the scientists have studied that in obesity, there is higher expression of non-classical monocytes, and when the patient fasts, there is diminution of these non-classical monocytes. So that is very interesting thing which I came across. Otherwise, it is a well-known fact that the monocytes are involved in atherosclerosis and Alzheimer's and certain other diseases like cancer, COPD, and fibrosis. And this article by Kaplos et al. Also discusses some of the antigens which are upregulated and downregulated in these conditions. So coming to the dendritic cells, so dendritic cells are broadly classified into myeloid-derived dendritic cells and something called stromal-derived dendritic cells. So myeloid, as the name suggests, myeloid dendritic cells express the myeloid antigens like CD13, CD33. So these are expressed in these dendritic cells. And they include interstitial dendritic cells, which are derived from the monocytic precursors, and something called Langerhans dendritic cell and plasmacyte dendritic cells. The mesenchymal dendritic cells are further divided into follicular dendritic cells and fibroblastic reticular cells. So these terminologies, these different types of dendritic cells are important to understand because different disease phenotypes are originating from these different types of dendritic cell lineages. So this figure I have taken from the recent WHO. It states a different type of monocytes, macrophages, and dendritic cell lineages. So broadly, we have two important stem cells. One is our myeloid stem cell, which is 34 positive, and one we have entirely different lineage, which is called mesenchymal stem cells. So myeloid stem cells give rise to monocytic precursors, which further give rise to monocytes, and in the tissues it gives rise to macrophages, and a type of dendritic cell which is called interstitial dendritic cell. So this is also derived from our monocytes. Next lineage is this lineage. It doesn't have a name. It is just a precursor of these two important components. One is our Langerhans dendritic cell, and one is our plasmacytoid dendritic cells. So sometimes these are referred to as indeterminate cells, and we have a tumor, indeterminate cell tumor, which is derived from these precursors of these Langerhans dendritic cells. So, as I told, these precursors give rise to Langerhans dendritic cells, and these are further classified into something called veiled dendritic cells and interdigitating dendritic cells. So, this interdigitating dendritic cell is also important because it gives rise to another disease entity. And next, we have a very specialized dendritic cells called plasmacytoid dendritic cells. So now the name suggests as plasmacytoid because these dendritic cells are not like a typical dendritic cell. So typical dendritic cell will have a lot of projections and a lot of evaginations. But this plasmacytoid dendritic cells is basically a globular kind of like a plasma cell, rounded shape. So that is why although it has the properties of a dendritic cell, but the shape is like a globular plasma cells. So that's why they are called plasmacytoid dendritic cells. And these are these further give rise to activated plasmacytoid dendritic cells. Whereas the mesenchymal stem cells, as I told, is divided as fibroblastic and follicular dendritic cells. So we'll read about these cells when we go towards their diseases which are derived from them. So let's move on to classification. So in 2016, the Histiocytic Society came with this particular classification where they have divided into 5 important groups. So we have the L group, the H group, the M, R, and the C group. So basically, the word stands with their primary letter in their classification. So the L includes the Langerhans cell histiocytosis and the related diseases. The M stands for Malignant Histiocytosis. The H stands for the HLH and its various components. The R stands for mainly the Rosai-Dorfman Disease. The C stands for the non-Langerhans cell histiocytosis of skin and mucosa, basically the cutaneous non-Langerhans cell histiocytosis. So this is the classification which was proposed in 2016 by the Histiocytic Society. Whereas the WHO in its updated version shows this list of histiocytic and dendritic cell neoplasm. So what we will do is we will just go through all these kind of entities and also some of the entities which was listed by the Histiocytic Society. So all these conditions are quite rare. So what is common? What we usually see, what I have seen in my residency is the hemophagocytosis. That is what I see during my routine, in my routine reporting. So hemophagocytic lymphohistiocytosis is a collective term. It is often fatal syndrome, and it characterized by a massive immune activation with a lot of cytokine release. And there are particular criteria of clinical features that has been described. So it's a hypercytokinemia. There is accumulation of a lot of activated macrophages in all the organs and tissues, and they are classified as something called primary or secondary HLH. And we have this criteria in which they say that out of this 8, if 5 are positive, then we can diagnose HLH. So basically, this HLH requires a molecular diagnosis, and then we have a clinical criteria, which consists of 8 criteria, in which 5 should come positive. So the primary HLH, as the name suggests, has to be a genetic inherited condition, whereas the right side you will see a list of these secondary causes of HLH, which can be by any number of secondary processes, which include infections, malignancies, or any autoimmune disorders, or after a transplant. So why I have highlighted this malignancy triggered HLH is because of this case which I came across during my residency. This was a case of a 21-year-old male. He was a known case of DLBCL stage 3, and he received an R-CHOP, and he was in a complete remission. But he presented after 2 years with fever since 1 month and massive splenomegaly. So bone marrow was requested, and to look for any relapse or any infiltration by his previous disease. So the hemogram showed pancytopenia. His hemoglobin was 7.3, platelets was 22,000, and TLC was 2,000. So the aspirate was particulate. It was normocellular. Everything looked fine. There were no abnormal lymphoid cells. But what we came across was this increased number of histiocytes. So here, this is a panel of photographs which show these activated kind of macrophages with this long processes and this multiple vacuoles, which shows that the histiocyte was quite activated. And some of the histiocytes also showed hemophagocytosis. So we saw all kind of hemophagocytosis, the erythrophagocytosis, the granulophagocytosis, the thrombophagocitosis. Here I want to mention that the granulophagocytosis is quite specific for the HLH, because routinely we can see in any hypercellular marrow there can be increase in histiocytes, and that can show hemophagocytosis. But the granulophagocytosis, like here, this is degenerating neutrophil. So that is quite specific. You find that in your histiocyte, histiocyte eating a granulocyte precursor or a granulocyte. So that is quite specific for HLH. So the marrow of this particular gentleman showed quite edematous changes, and also there were increased in histiocytes, which are highlighted by the CD68 immunostain. The CD20 did not show any increase in any abnormal cells. 3 was like a normal distribution, and MPO was negative. So we gave the final diagnosis as marked hemophagocytosis with a T cell rich infiltrate. So we advised the repeat bone marrow because the marrow was very reactive. But after the repeat marrow also, there were increase in histiocytes, and that could probably explain the cytopenias that this person was having. Another scenario which I want to mention in this another case which I came across, so that was a 21-year-old male, and this is very young child. He had cytopenias on and off since birth. He was on transfusion, and currently when he came to us, he had bicytopenias, and there was a clinical suspicion of HLH. So for this child also, the marrow was hypocellular, and what we saw was these kind of increased histiocytes. So here also you can see this granulophagocytosis along with this platelet debris which is present in this histiocyte. And here you can see erythrophagocytosis. So granulophagocytosis is quite specific for HLH. So this child also showed increase in histiocytes, and it was advised to go for a genetic testing to find all those mutations which are involved in the phagosome formation and subsequent release. So these are the two situations in which we got increase in histiocyte in HLH. One could be a secondary cause by malignancy induced, or and the other was something which we believe could be a primary HLH because it presented very young. So that was about the HLH. So let's move on to the tumor cells derived from the Langerhans cells. So in this, we have the two important entities, the Langerhans cells histiocytosis and the Langerhans cells sarcoma. So Langerhans cell histiocytosis have very fancy names which are generally obsolete in nowadays. But still, I would like to mention the Hand-Schuller-Christian disease or the Litter-Seewage disease. These are obsolete terms, but they are usually denoted, the multiple lesions usually is denoted by this Hand-Schuller-Christian disease, whereas the disseminated form with the visceral involvement is called as Litter-Seewage disease. So coming to the Langerhans cell histiocytosis, it's basically a disease of a childhood and has a male predilection. And there is a specific subclassification of a primary LCH of lung, and it is almost always seen in smokers. It's basically a disease which is presented with the nodules in the lungs, and they say that it usually resolves when the patient stops smoking. So this LCH can be localized to a single site, or it can involve multiple sites. So it can be a solitary form in which it is most commonly involved the bone or the adjacent tissue, it can be a single organ but multifocal disease. So that also is usually it involves bone. And then we have a third variety in which it is a multi-system disease, and the multi-system disease is mostly seen in very young children, in infants. So important to note here is that the gonads and the kidney are usually spared by the LCH, even in the disseminated cases. So coming to the LCH pathogenesis, so the bottom line to understand in this particular pathogenesis is that there is activation of this ERK. So ERK is activated, and that leads to LCH. So ERK can be activated by the activating mutations of this BRAF or the activating mutations of this MAP2K1. So these two are important to understand because now we have a targeted therapy against this. So ultimately what is going on is that ERK is activated, and that leads to formation of this LCH disease. On the right side, you can see that the ERK activation can happen at the level of hematopoietic cells. It can happen at the level of circulating precursors. It can happen at the level of restricted precursors, or it can occur at the level of dendritic cell precursors. So based on the activation at what level it's happening, they can be divided as a high risk multisystem LCH if it's happening at the level of precursor hematopoietic stem cell level. And if it is happening at the later stages, it usually gives rise to a low risk LCH. So microscopy shows oval cells with a grooved indented nuclei. The chromatin is very fine. The nucleoli is inconspicuous. It's not a very overtly malignant looking disease. And it has a grooved, the nuclei are usually grooved coffee bean-like appearance. And the membranes are thin. The nuclear atypia is very minimal. Mitotic activity can be very variable. There are cases where have a very high mitotic activity, but we don't see very atypical mitosis in this disease. And the cytoplasm is moderately abundant to slightly eosinophilic. Apart from these grooved coffee bean-like cells, we have a background which predominantly includes eosinophils. Sometimes we have eosinophil abscess. So those eosinophils can be very much aggregated, and that sometimes they can obscure the actual these LCH cells. So the background characteristic milieu is very important to understand. So we can have variable number of eosinophils, other histiocytes, neutrophils, or lymphocytes. So as I mentioned, there could be eosinophilic abscess, and then Charcot-Leyden crystals can also be seen. In early lesions, LCH cells are usually predominating, but whenever we came across the late lesions, this reactive phenomenon overcomes. So the macrophages and the fibrosis, they overcome, and sometimes these LCH cells can be missed. So this figure shows these kind of grooved cells, and these are positive, showing membranous positivity for CD1A, which is seen in these cases, and I'll discuss about it in further slides. And then here you can see these increased number of eosinophils, and sometimes they are so large that they form the eosinophilic abscess. So other organs include the spleen, in which the red pulp is involved. The liver shows a strong preference for intrahepatic biliary involvement with sclerosing cholangitis. Large clusters or sheets of LCH cells can be found with other neoplasms like your lymphomas and sarcomas. It can be a reactive phenomenon, but some of the literature shows that they have a same clonal immunoglobulin rearrangement like that of the lymphoma cells. So they can appear as a trans-differentiation process. They can come from the same clone of cells from where these lymphomas have originated. So this is important concept that you have to understand, that the trans-differentiation process can occur whenever LCH coincide with the lymphomas. So ultrastructure is characterized by this presence of this Berber granules. It looks like a tennis racket with a zipper-like pattern of striations, often with bulbous ending. Immunophenotype, the three important Langerhans markers is your CD1A, the Langerhans, which is also called CD207, and the S100 protein. In addition, so these are the three important Langerhans cell, classical Langerhans cell markers. Apart from these, they can be positive for Vimentin, CD68, or HLA-DR. These are usually absent for the B and T cell lineage markers, CD30, and follicular dendritic cell markers. Expression of PD-L1 is seen in many cases. So again, I would like to mention another case which I came across during my residency in cytopathology department of a case of 35-year-old male. He presented with enlarged multiple cervical lymph nodes, and FNAC was done from the bilateral cervical lymph nodes. We aspirated a 2 ml of fluidy material. It was quite cellular, so this is your GIMSA preparation and this is your HNE preparation. So you can see it's quite cellular. These cells are usually in cohesive clusters. This is a high power view to show these kind of cells with abundant cytoplasm. Some of them are eccentrically placed, and the background show these neutrophils, lymphocytes. This is an HNE view to show these kind of cells. So multiple pictures to show these characteristic grooves within the cells. So these are the grooves within the cells, and the background shows the neutrophils. So this is quite classical cell which is showing these kind of grooves, and it resembles like a coffee bean nuclei. So apart from this coffee bean nuclei, we also found a lot of histiocytes. Some of them were kind of epithelioid looking, and there were histiocytic collections in the background along with neutrophils, lymphocytes, and eosinophils. We also found the increase in mitosis, but there were, so this is increase in mitosis, but there were not any atypical mitosis that we saw. So this is basically another area which showed increase in this histiocytes. It is quite active, which is engulfing all these components. So background also showed increase in histiocytes, mainly a reactive process, and which showing hemophagocytosis. We made a cell block from this, and the cell block was positive. It was quite cellular, and it was positive for CD1A. So this is a high part to show this membranous positivity for CD1A. CD68 highlighted the background increase in histiocytes. It was negative in the Langerhans cells. The final impression that we gave was Langerhans cell histiocytosis. So it's so this patient presented with bilateral enlarged cervical lymph nodes, and this coffee bean nuclei, CD1A positivity, and characteristic background milieu clinched the diagnosis. So coming to the molecular studies, BRAF mutation, as I told, there is activating mutation of ERK, and there that whole chain of the markers becomes activated. So this BRAF mutation is found in 50 to 64% of the cases. In some of the cases, it is the variant allele frequency is quite low, so we need very high sensitivity techniques to diagnose this condition. If the BRAF is negative, the other mutations which have shown to be positive is the MAP mutations, or the other mutation including the RAS, ARAF, or MAP kinase. Basically, all the MAP kinase pathway mutations are activated, and the end result is activation of the ERK. So why it is important, as I told earlier, there is a targeted therapy. So for BRAF, we have the vemurafenib, which is the targeted therapy approved for this BRAF mutation. The prognosis wise, if it's a unifocal disease, then it has an excellent survival, whereas it is a multisystem, as the multisystem or a disseminated disease comes, the prognosis drops. But the involvement of bone marrow, liver, or lung is considered as a high risk factor. So coming to the another end of this LCH, it's called sarcoma. As the name suggests, it's a very aggressive looking, very highly mitotic, and very so the LCH was like a bland looking tumor. There was inconspicuous nucleoli. The mitosis was not very atypical. The atypia was not very prominent. But in the sarcoma, Langerhans cell sarcoma, it's a high grade neoplasm, and it has all the features of a high grade malignancies. So it's a high-grade neoplasm with malignant cytological features, and the phenotype is like a Langerhans cells. So etiology, important thing to mention here is this Merkel cell polyoma virus sequences, which has been identified in a subset of cases of Langerhans cell sarcoma. It has a predilection for skin and underlying soft tissue, which is the most common site for its involvement. It's an aggressive tumor, high-grade malignancy, and mortality rate is also high. So this the feature. So it's a very pleomorphic tumor. As I told, the chromatin is very clumped, like any other malignant tumor, and nucleoli are prominent. They are conspicuous, and there are mitosis rate is quite high. There are atypical mitosis which is present, and the grooves are also very complex. So usually we see single kind of groove in LCH. So these have like a multiple grooves, complex grooves in the cells of Langerhans cell sarcoma. So coming to the next other entities of this WHO classification, first we will study about the histiocytic sarcoma. So histiocytic sarcoma is a malignant proliferation of cells showing morphological and immunophenotypic features of mature tissue histiocytes. So like LCH was a disease of childhood, this occurs mainly in the adults and has a male predilection. There are some associations with this histiocytic sarcoma that we have to remember. One is your low-grade lymphoma. So I would like to mention here that all the histiocytic lesions have some kind of association with other hematopoietic malignancies. In that, the most common are lymphomas. So lymphomas and histiocytic tumors go side by side, and there are numerous case reports of their co-association. So for histiocytic sarcoma, the low-grade lymphoma, especially the CLLs and the follicular lymphomas, are most commonly involved, and it is also associated with myelodysplasia and are mediastinal germ cell tumors. They usually present like a solitary mass and sometimes associated with systemic symptoms. If it's a disseminated form, it is called malignant histiocytosis. So it is basically a non-cohesive proliferation of very large cells. So since histiocyte is a large cell, so histiocytic sarcoma is also characterized by very, very large cells. The cells are usually eccentrically placed, and they have prominent conspicuous nucleoli. They have a xanthomatous appearance. The nuclear atypia, they are atypical pleomorphic nuclei, and mitosis can also be conspicuous. Another important point to remember here is that erythrophagocytosis is sometimes seen. It can be very prominent in this histiocytic sarcoma. So histiocytic sarcoma is usually sometimes confused with something called myeloid sarcoma. Especially myeloid sarcoma with a monocytic differentiation. So that also has a similar kind of appearance, large cells, eccentrically placed monocytoid kind of cells. So what is important what is the important marker here is this NMP1. So NMP1 shows the characteristic cytoplasmic as well as membranous. So this membranous positivity and cytoplasmic positivity, which is not seen in your histiocytic sarcoma. So in the inset of the histiocytic sarcoma, I have shown CD11C, which is negative in the myeloid sarcoma, but the NPM1 positivity is seen, this which is not seen in your histiocytic sarcoma, and the internal control for this NPM1 is these lymphocytes. So lymphocytes show a strong nuclear positivity for NMP1. So this important differential diagnosis we have to keep in mind. So histiocytic sarcoma immunophenotype is your histiocytic markers like CD68, 163 and lysozyme. So we have to remember their staining pattern also, like 163 has a membranous, or it can be a cytoplasmic pattern of positivity. 68 has a characteristic granular cytoplasmic staining, and lysozyme has a cytoplasmic staining which is accentuated in the Golgi region. There is absence of the typical Langerhans cell markers, and but focal S100 positivity can be there. Follicular dendritic cell markers can also come positive, and myeloid markers are also negative. The genetic profile, important to note here is that there is clonal immunoglobulin rearrangement, especially when they are associated with some kinds of lymphomas, which I had discussed, like a transdifferentiation phenomenon. Then we have, whenever it is associated with mediastinal germ cell tumor, it shows positivity with isochromosome 12p. They can also be positive for the mutation of that RAS-RAF pathway that has also been reported here, and activating mutations of another pathway, PI3-AKT-mTOR pathway, and cyclin, copy loss of cyclin-dependent kinase gene has also been reported. It's an aggressive neoplasm, has a very high mortality and poor response to therapy. And patients with a localized disease or a small primary tumors have a more favorable outcome. So next, let's go to indeterminate dendritic cell tumor. So here I just want to recapitulate that the indeterminate dendritic cell is basically a precursor of your Langerhans cells. So it's a precursor of the Langerhans cells, and basically it's proliferation of those cells which give rise to indeterminate dendritic cell tumor. So they can present, usually they are presented in the skin with papules, nodules or plaque, and systemic symptoms are rare. The skin cell lesions are predominantly of dermal, they localize to the dermis, and the tumor cells may resemble LCH cells and show a more heterogeneous cytological features. Like there can be a prominent spindle cell component which is not seen in, usually not seen in the LCH. Eosinophilic infiltrate can also be there, but it is extremely variable. So what is differentiating from its LCH? Because as I told that indeterminate dendritic cell is basically the precursor of the Langerhans cells. So what it is differentiating from the Langerhans cells is that it does not show the bedbug granules which is seen in the LCH cells. Another, it lacks these Langerhans expression which is seen in our LCH. So BRAF and the MAP kinase related mutations are also absent, and what is present is this ETV3 and CO2 gene fusion, which is detected in 4 cases in one of the series, the reference I have written below. So that is the important thing that we have to understand, that these do not have the Bilbek granules, these do not have the Langerhans expression, and these do not have the BRAF mutations. So this is the slide which I have taken from this this article, which shows these kind of indeterminate cell sarcoma with some of the spindle cell component that you have to appreciate. So that is one of thing which is very prominent in these kind of tumors, and this instead shows the absence of CD207, that is Langerhans. So that also favors the diagnosis of indeterminate cell. So next, let's go move ahead with interdigitating dendritic cell tumor. Just to recapitulate that interdigitating dendritic cell tumor was arising from the Langerhans cells along with your veiled cells. So it's very rare disease, and it phenotype comprises of normal interdigitating cells who have on ultrastructure, they have interdigitating processes, and that's how the name arises. They have a solitary lymph node involvement, and the patient can present like an asymptomatic mass, and rarely there can be a localized or generalized lymphadenopathy, splenomegaly or hepatomegaly. So microscopically, what is important in this is the tumor cells are arranged in the form of story-form pattern, like a fascicles or whorls, and the cells can range from spindle to ovoid cells. And the cytoplasm is usually abundant, and sometimes it has a syncytial kind of appearance with indistinct cell borders. They may show some kind of indentations or vesicular chromatin and distinct nuclei. The mitotic rate is low, and the background shows numerous admixed lymphocytes along with plasma cells. So this show these kind of cells which have a conspicuous nuclei, and the background shows a large number of lymphocytes and sometimes plasma cells. So as I told, they have a complex interdigitating cell processes which is seen on electron microscopy. And the immunophenotype which we have to remember in this is that they do arise from Langerhans cells, but they lose the expression of CD207, and CD1A. So Langerhans and 1A are downregulated, but they retain S100 positivity. And another important molecule which is expressed on this cells is SOX10 molecule. So SOX10 and S100 positivity is the marker that we have to remember in this interdigitating dendritic cell sarcoma. Another markers is our P53, which shows strong expression, nuclear expression. Then we have PASIN, and the background lymphocytes are mainly of T cell origin with near absence of T cells. So the T cell lineage in the background and the cells showing S100 and SOX10 is very helpful in the diagnosis, along with the morphology of those cells. And it's generally an aggressive tumor and have a very high mortality rate. So next, move on to follicular dendritic cell sarcoma. It's very important tumor because it has a very characteristic immunophenotype. So it's basically a proliferation of, it's a sarcoma, it's a proliferation of ovoid two spindle cells and have a immunophenotype which is characteristic of this follicular dendritic cells. There are some associations that we have to remember. First and foremost, and very important, is this hyaline vascular Castleman's disease. It can arise with this, it can arise before this, it can arise after this. So that association is very important to understand. Another important things to understand is their association with autoimmune disorders like pemphigus, paraneoplastic pemphigus, myasthenia gravis, or multi-organ syndromes. And as already mentioned, lymphomas are there wherever these entities are. Extranodal, in terms of their localization, it is an extranodal disease that is most commonly involved compared to our nodal disease. But it's a slow-growing tumor. It's present like a painless mass lesion, and there can be very large masses of this tumors, as large as 7 centimeters. This again is arranged in the fascicle, storiform arrays or whorls. They have indistinct cell borders. Cytological atypia can be significant, and this important component is nuclear molding. So that is frequently found in these kind of cases, and it is the background shows lymphocytes. So as we studied in interdigitating dendritic cells, that on ultrastructure we find interdigitating cells. In this follicular dendritic cells, it shows presence of this desmosomes on ultrastructure. So that is something to keep in mind. So this is the picture to show this complex nuclear moldings. These are the nuclear moldings. So that is something that you have to look for, along with this kind of story form or whirling pattern of this spindle to ovoid cells, along with the immunophenotype, of course. So immunophenotype follicular dendritic cell is quite specific. They are positive for CD21, CD35, and CD22. That we have to remember. Apart from these three specific markers, we have to remember the CXCL13 and something called podoplanin. And another molecule which is called clustrin is very important to keep in mind because it is usually negative or only weakly positive in other dendritic cell tumors. So clustrin is another important marker that we have to keep in mind. And other markers are like desmoplakin, vimentin, PASIN, but these are very overlapping with other. So what is important to understand is the follicular dendritic cell marker. You have to keep in mind CXCL13, podoplanin, and clustrin. Recently, two important other markers have been reported, and that is follicular dendritic cell secreted protein, that is FDC SP, and something called SIR-glycin and PTL1. So these two are recently reported in these follicular dendritic cell sarcoma. Prognosis-wise, there are certain factors which governs the prognosis. So if it's a large tumor size, if we have a coagulative necrosis or very high mitotic content or a significant atypia, that can give rise to a worse prognosis. So important to note here is that conventional follicular dendritic cell sarcoma are usually negative for EBV. So why I have mentioned here is that, so it has a subtype of follicular dendritic cell sarcoma which is called inflammatory pseudotumor-like variant, which is EBV negative. So that is important thing to keep in mind. These are EBV negative. Follicular dendritic cell sarcomas are EBV negative. So what is positive is this pseudotumor-like follicular or fibroblastic dendritic cell sarcoma. So what are the important things to remember in this particular entity is that it occurs in females and young females. So that is the age criteria for this, and it typically involves the liver or spleen and has a very prominent lymphoplasmacytic infiltrate, as the name suggests. The inflammatory background is quite prominent in these kind of tumors. So other important things is the presence of this histiocytic or granulomatous reaction. We can have a fibrinoid deposits around the blood vessels, and the neoplastic cells are positive for follicular dendritic cell markers like 21 and 35. And but in some cases, these in some of the this condition, in some of these cases, the follicular dendritic cell markers are negative. So what is positive in those cases is your SMA, that is smooth muscle actin. So that is positive, and that is from this dendritic cell switching on to something called myofibroblastic side. So that is called a phenotypic switch. So this especially occurs whenever the follicular dendritic cell markers are negative. It doesn't happen in all the inflammatory pseudotumor-like dendritic cell sarcomas, but whenever it happens, so they have found that SMA is positive, and that is a phenomenon which shows phenotypic switch. And as I mentioned, these are consistently associated with EBV infection. So this is a panel of photograph which shows this inflammatory pseudotumor-like sarcoma. This first shows the histological pictures from the spleen, which shows this side involved side and this side the normal side. Then we have these cells. So these have characteristic morphology, and the background is very important to understand. And they are positive they are related to EBV. The EBAR is positive, and some of the cells also show positivity for follicular dendritic cell markers. So next, quickly move on to fibroblastic reticular cell tumor. It's extremely rare tumor. So this occurs in lymph nodes, spleen, or soft tissue, and the histology is very similar to its other counterparts like follicular dendritic cell sarcoma, which is arising from the mesenchymal origin, or interdigitating dendritic cell sarcoma, but it lacks its characteristic immunophenotype. So what is positive in this is SMA, desmin, and cytokeratin, and along with CD68. So ultrastructurally, these cells of fibroblastic reticular cell tumor, they show a spindle cell arrangement with cytoplasmic extension like a myofibroblast. So that's why they are positive, also positive for SMA and desmin. So this is the important thing to remember in this particular tumor. Coming to the disseminated juvenile xanthogranuloma and Erdheim-Chester disease, I'll discuss them together. So disseminated juvenile xanthogranuloma is characterized by presence of this xanthomatous foamy histiocytes and something called Teuton-type giant cells. So these are the two important things that we have to remember in this particular entity on morphology. And its important association is its association with neurofibromatosis type 1 and JMML. So these are the two important entities which are quite often associated with this particular entity. It has a predilection for head and neck, skin and soft tissue, whereas the disseminated forms involves the upper aerodigestive tract. It is usually benign, but it can be associated with a full-blown macrophage activation syndrome, and that can lead to death. But unlike its very similar morphology looking like Erdheim-Chester disease, so that this particular entity does not have a BRAF mutation. So this is the panel of photograph which shows the different presentation of the juvenile xanthogranulomatous disease. We have a classical form in which we have a shiny papules. Then we have benign cephalic histiocytosis. We have a disseminated form. Then we have reticulohistiocytosis. And then we have the nodular histiocytosis, which involves usually the older patients. Microscopically, this disseminated juvenile xanthogranuloma shows small, bland, round to oval cells with grooves. and the Tutan cells are present, but they are less common whenever there is a non-dermal involvement. And the cells are progressively lipidized, so it's a xanthomatous appearance of these histiocytes, like a foamy kind of appearance. So this insert shows these Tutan type of giant cells and this foamy appearance of these histiocytes. The immunophenotype shows markers positive for the histiocytes like 14 and 68, 163 is positive, factor 13A is positive, which is shown here, but it is not specific for this particular disease. So these have a very overlapping markers of histiocytes and other. But important to understand here is that these are the CD1 and Langerhans, that is of Langerhans cells markers. They are consistently negative. So coming to the Erdheim-Chester disease, Erdheim-Chester disease is basically named after the scientist Erdheim and his mentor Chester. So it is a clonal proliferation of histiocytes, and it also has a foamy component and a Tutan type genesis like we saw in the previous entry. And usually it involves the adults with a male predominance. They say that virtually any organ or tissue can be infiltrated, and usually the presentation is like, the first presentation is like a multi-system involvement. Erdheim-Chester disease mainly involves the long bones, that is the most common site of its involvement, and then next followed by the cardiovascular involvement, and then the retroperitoneal involvement. The retroperitoneal involvement is important to note, and what happens in the CVS part is the presence of this coated aorta. So what happens is that there is soft tissue sheathing of this thoracic and abdominal aorta, which is called the coated aorta, and this sheathing also involves the renal perirenal fat and also the pericardium. So pericardium, all this sheathing occurs in the heart, in the pericardium, in the right side of the heart especially, and in the perirenal areas. Apart from that, there is osteosclerosis of the long bones. So this shows the osteosclerosis of this long bones, and this perirenal involvement is there. And so apart from that, there is orbital infiltration, there is pituitary gland infiltration, and there is CNS infiltration, and we have subsequent manifestation based on these system involvement. So the coated aorta is something that you have to remember, and osteosclerosis of long bones, because that is like 95% of the cases will have the involvement of this long bones. Microscopically shows this foamy or xanthomatous cells, and Tutan type of giant cells is present. There is fibrosis in the background, which is present in most of the cases, and also the background shows reactive lymphocytes, plasma cells, and neutrophils. This particular group, Diamond et al. Came across this consensus diagnostic criteria for Erdheim-Chester disease, and they say that these three are the important component of this diagnostic criteria. So the first is your xanthogranulomatous lesions, which are CD68 positive and 1E negative histiocytes. We have a symmetrical skeletal uptake of long bones of the legs on these imaging techniques. And the third is the involvement of at least one other organ apart from the bone, typically the orbit involvement or the renal involvement, or something which I have mentioned, the coated aorta. So the heart, kidney, or the orbit involvement, which is frequently seen in these cases, that is another component of this criteria. So Erdheim-Chester disease express macrophage markers like 1468 and 163. Factor 13A and FASN is also positive, but Langerhans cell markers are usually negative. The cell of origin is still debatable, but some studies have revealed that it could be an interstitial dendritic cell. So this is the panel of photograph which shows immunostain positivity in the case of Erdheim-Chester disease. So this is the histiocytes which are positive for CD68, CD163, and factor 13 is negative on these histiocytes, but it stains the other cells of this neoplastic process. Genetic profile, BRAF is consistently positive. It is reported in more than 50% of the cases. MAP kinase, ARAF, and other components of this BRAF pathway are also positive. And some of the cases have also reported mutations in PI3K pathway genes. And some of the cases have also reported positivity for something called ALK, but now they understand that it is a different entity. It has been reported as a different entity, and it is called ALK-Positive Histiocytosis. So this is a distinct entity now, although it is not mentioned in WHO, but it is mentioned in many of the other literature. So what it characterizes is that it is characterized by this translocation involving KIF5B and ALK. It is the characteristic case. It is very rare tumor. I think 10 or 12 cases have been reported in the past. And the characteristic clinical scenario is that of a very young infant, which shows hepatosplenomegaly and transfusion-dependent cytopenias, transfusion-dependent severe cytopenias that last over months. And because of this translocation, ALK protein is expressed both in the cytoplasm and the cell membrane. So these patterns are described. Morphology resembles Erdheim-Chester Disease or Rosai-Dorfman Disease. And but important to note here that BRAF is usually negative, and CD1A and CD207 is usually negative. So that is one entity of Erdheim-Chester disease. So BRAF mutation is seen in quite a lot of other cases, especially the LCH. And I want to mention here is that there are cases reported in the literature where Erdheim-Chester disease and LCH has been reported together. So there are lesions where both of these components are reported together. So they are together. They are also called like an inflammatory myeloid neoplasm. And the authors describe that they may have a common precursor, and then during the differentiation they go on to a different lines, but they can have a common precursor. So that's why there are many case reports in which both of these conditions have been described together. So this is a picture of ALK histiocytosis. So here you can see large cells, histiocytes, foamy histiocytes. So the morphology is quite like a Erdheim-Chester disease, and this inset shows positivity of this ALK protein, which shows positivity for both membranous as well as cytoplasmic. So here we can also see some kind of this emperipolesis, which I'll discuss in my next entity. So that is seen in Rosai-Dorfman disease. So this particular entity can have morphology like Erdheim-Chester disease and the ALK disease. So coming to the last part of our class, this is called Rosai-Dorfman disease. So this is so RDD is basically stands for Rosai-Dorfman and disease. It's not just Rosai-Dorfman. So I would like to acknowledge this disease because this disease is also called the RDD disease is also called disease. So he was a French pathologist. So here on the right side, he was a French pathologist who first described this disease in a family of children. Then after that, this one Rosai and Dorfman described these cases a few years later in a large population. But the first introduction was because of this French pathologist Distombus, and that's why it's also called as Distombus disease, or another term is the sinus histiocytosis with massive lymphadenopathy. So it is basically infiltration of the macrophages which express S100 protein and show emperipolesis. Emperipolesis is just like a phagocytosis, but it involves the live engulfment of the live cells. So that is emperipolesis. So these two components are most important, S100 and emperipolesis. It usually involves the young individuals and they present with bilateral cervical lymphadenopathy. Location-wise, the most common involvement is the nasal and the paranasal sinuses, ophthalmic tissues, skin and bones. That is involved in 43% of the cases, and in 23 there is extranodal involvement, and in around 19% there is systemic involvement. Patients often present with fever, hyperglycemia, ESR elevated, and anemia, and also neutrophilia. However, I want to mention here is that the bone marrow infiltration is rare. So what are the association for this Rosai-Dorfman disease? They say in 10% of the cases it is associated with some kind of autoimmune disease like SLE or juvenile arthritis or hemolytic anemia. IgG4 positive plasma cells can be elevated, and sometimes they can even reach up to the cutoff value that is decided for the IgG4 related diseases. So its evaluation, the ratio evaluation is quite important. So this point we have to keep in the mind. So another association is the presence of myelodysplasia and after bone marrow transplantation of acute leukemia, and rarely it can be associated with LCH or Erdheim-Chester. Microscopically, the lymph node shows thick fibrotic capsule. There are dilated sinuses, these which are filled by these macrophages. There's a prominent plasma cell infiltrate in the remaining parenchyma. These intrasinusoidal macrophages show multiple round nuclei, fine chromatin, and often prominent nucleoli. Cytoplasm is abundant, and the background shows variable number of lymphocytes, neutrophils, and plasma cells. And important to note here is this emperipolysis. So this is basically engulfment of the live cells. This is a view to show this Rosai-Dorfman disease, in which there is a background shows lymphocytes and there is a mixture of these histiocytes, and some of them will show these kind of emperipolysis. The immunophenotype shows positivity for S100, that is important marker to remember. In addition, we have CD11C, 1468, 163. Other Langerhans cell markers apart from S100 are negative, and plasma cells are usually polyclonal, and as I mentioned, they are IgG4 positive. So I would like to end the discussion of Rosai-Dorfman disease by mentioning of some of the diseases which can have inherited predisposition, and that is because of this gene which is called SLC29A3. It usually gives rise to a transmembranous protein, and the condition which are associated with this inherited Rosai-Dorfman disease is familial histiocytosis syndrome, which is also called Faisalabad histiocytosis, and we have something called H syndrome. So what happens is quickly that in the normal cells, this SLC protein which will cause a degradation of these something called G or DG. These are the nucleosides. So in the normal healthy subjects, this is SLC protein which is not mutated. It causes degradation of these nucleosides. It will make these nucleosides move out of the cells, and this will lead to downregulation of this toll-like receptor 7. But whenever this is mutated, this nucleoside level within this phagosome. So this is a this is basically a macrophage, and this small circle is our phagosome. So this nucleosides level will go up, and this will cause recruitment and increase in this toll-like receptor 7, and that will lead to proliferation, that will drive the proliferation of histiocytosis. So that is important this particular mutation is important to understand. So now we have come to our last entity, and I would like to end my discussion with another case that I came across during my residency of a 64. This is quite interesting case because we don't see this case quite often. It's a very rare tumor. So this was a 64-year-old male. He presented with fever and easy fatigability along with mild hepatosplenomegaly. On evaluation, pancytopenia was found, and bone marrow was advised in view of any CLPD or any MDS because he had cytopenias. So he did have cytopenias. There was hemoglobin of 7.9, platelet was 8, and TLC was just 900. And the predominant population was lymphocytes, but there were no abnormal kind of lymphoids. But in the periphery, we did find these kind of circulating immature cells. They were very rare, like 1 or 2%. They didn't even come in our differential count during first two when we reported this case. So when we looked into the morphology of the bone marrow, then again we went back and these cells were found. So these were quite large cells. They had a very immature kind of phenotype, like a blast kind of cells. The marrow was aparticulate, it was hemodiluted, but we did see these kind of large cohesive clusters. It gave impression of could it be a non-hematopoietic origin of cells, because they were very cohesively present. These kind of rosettes formation also. So here you can see this kind of rosette formation. So like a gland formation. So that was one, that differential also came in our mind, that could it be a metastasis of a non-hematopoietic lineage. But when we, on the high power view, they were quite blastoid kind of cells. They have a very mature chromatin, very prominent nucleoli. MPO and PS was negative. We had a good internal controls. And the biopsy showed these kind of rosette appearing of the cell. This was quite characteristic. So here also you can see these rosette formation in these cells. The IHCs were negative for the routine markers. 34 was negative, 320 MPO was negative, the usual BT MPO lineage tumors was negative. Cytokeratin was also negative, so that ruled out any non-hematopoietic malignancy by large, but the CD45 came out to be positive. We did a flow, so just quickly going through the summary of flow, and it was positive for CD45, HLA-DR 123, 56, 4, 58, 38, 33, 81 and 86. So important here to understand is this 123, 56 markers. So and then there are other B cell and the immaturity markers were negative. So that was, we came across this entity, that is the blastic plasmacytoid dendritic cell neoplasm. Before going to that particular disease, I would like to just quickly mention that pseudo-rosette formation can be seen in these kind of lymphomas, the CNS lymphoma, follicular lymphoma, T and NK cell lymphoma, and BPDCN. So that morphology was quite characteristic in this. So when we looked into the literature, these lymphomas have been reported to show the pseudo-rosette formation. So BPDCN is quite a rare malignancy. Only 0.44% of all the hematological malignancies are accounted. They usually present with skin manifestation, which is the most frequent finding, and the regional lymphadenopathy is there. And the peripheral blood and bone marrow involvement is seen in very advanced stage. The morphology is that of immature blastic cytomorphology, and the mitosis is quite increased. So this entity is not mentioned in WHO along with the histiocytic classification, because it has a very similar clinical and biological profile with that of acute myeloid leukemia. So that is where the WHO has placed this entity. It's a separate entity in the WHO. Immunophenotype is quite characteristic. So there is absence of the routine lineage markers, and there is positivity with CD4, CD45, CD56 and CD123. So that is considered as the unique phenotype, which is virtually pathognomic for this entity. And also CD303 positivities has a very high diagnostic score. We didn't do it in our flow panel, but it is mentioned again. So this is basically the antigen. This table shows, which I have taken from this particular article, which shows the expression of antigen in the BPDCN, and also the normal plasmacytoid dendritic cell, which is from where the BPDCN arises. So we have the antigens which is expressed by both normal as well as BPDCN. We have antigens which is expressed by normal but not by the BPDCN, and if at all they are expressed by this tumor, they are expressed just like a dot positivity and not like a diffuse cytoplasmic positivity. This is very important. You can look into this table closely. And then we have the markers which are quite specific for BPDCN, in which CD56 and BCL2 is important, along with CD7 and also CD3. They have mentioned that it is expressed in BPDCN, along with occasional expression of other markers which is not seen in the normal plasmacytoid dendritic cell. So I would like to end my discussion with this FDA-approved drug. Since I told that CD123 is quite frequently expressed in this BPDCN, so FDA has approved Elzonris, which is a targeted therapy for this particular entity, which is anti-CD123 target therapy. So yeah, that's about it. So these are my references, and thank you. So this is my alma mater, PGI Chandigarh.
Thank you so much. Wonderful presentation, very extensive, and of course this is a very difficult topic, and Very nicely explained, Dr. Harpreet. And Dr. Ramesh would like to know what is the prognosis of BRAF mutation?
BRAF mutation basically has a poor prognosis, and BRAF is not specific for histiocytic tumors. We see in melanomas, in papillary carcinoma of thyroids, ovarian tumors, colorectal tumors. So it has an overall bad prognosis, and it has also increased resistance to first-line therapy. And they also say that whenever there is BRAF mutation, there is increased propensity of neurodegeneration, which also leads towards increased mortality. So it has a bad prognosis.
Right. Dr. Pulkit is there if you would like to make a comment.
Yeah, it is indeed a
Hello, sir.
nice compilation by Harpreet. And I would like to just add a few things. So benign histiocytic disorders is one end of the spectrum, in which HLH is straightforward, easy diagnosis. But there are other benign histiocytic lesions like dermatopathic lymphadenitis or other reactive histiocytosis, which needs to be distinguished from LCH, especially in children, because sometimes we do get lymph nodes in which we have the typical paracortical expansion and expansion of Langerhans cells. Do become sometimes very difficult to distinguish benign versus a Langerhans cell histiocytosis, because the Langerhans cells have phenotype of CD1A positive, CD207 positive. Then how to distinguish the reactive dermatopathic lymphadenitis versus a LCH? So sometimes the clues are, yes, you have those pigmented histiocytes within the sinuses, but the certain soft pointers are that in cases of LCH, you have the infiltration of the sinuses of the lymph nodes by the Langerhans cell histiocytosis. So if the sinuses are involved, the subcortical sinuses, it favors a diagnosis of LCH over a dermatopathic lymphadenitis, and obviously the eosinophilic infiltrate favors LCH over dermatopathic. So this is one of the pitfall of the diagnosis of LCH. And another point is, I think recently the histiocytic the one paper has come in the blood which has classified it into the 6-7 types: the L group, the LCH group, or the C group, or the M group. So they have divided based on the topography or the pathogenesis of the histiocytic lesions. Like the most prominent group is the cutaneous histiocytosis, in which there are n number of entities, of which she has described the xanthogranulomas and that benign cephalic histiocytosis, all those things. And then obviously the malignant ones she has described very well. So these are these are certain points which I would like to add. That's it from my side. Over.
Thank you, sir.
Right. Absolutely right. There are some comments on the YouTube. Dr. Shrikant Gurvinder says, very good presentation. Prabjeet Kaur says, excellent topic and nice presentation, Dr. Harpreet. Keep it up. Dr. G.S. Virk says, excellent topic and beautifully explained. I would agree with him, absolutely. Very nicely explained, compiled very well. It's a real hard work done, excellently done. Thank you, Dr. Harpreet, for coming on this platform and sharing your knowledge and teaching us such a difficult topic in such an easy way. Thank you so much.
Thank you, sir.
Right. Would you like to make any closing comment before we close?
No, sir. Thank you. I would like to just acknowledge my alma mater, PGI. Whatever I have learned is because of this. I'm still learning. So,
right.
all my teachers.
That applies to all of us here. Thank you.
Yes.
Right. Take care. Bye-bye then. Good night.
Okay, sir.
God
Bye.
bless you.
Good night.
Bye. Thank you. Bye. Please share the PDF of this lecture so that we can share it with the students.
Okay, sir. Bye.
Thank you so much. Bye.